Hey, welcome back. I wanted to kind of cover something a little different, and it's about Airway, but this comes from the National Association of State EMS Officials Evidence-Based Guidelines. I want to cover some of this because evidence-based medicine, you will find questions on registry about this, and I think it's good to go over. So the purpose of airway management is to ensure effective oxygenation and ventilation, preventing hypoxia and associated complications. Effective airway management saves lives. It mitigates severe complications in the critical patient. And so when we talk about airway management is the cornerstone of EMS practice. I remember we were at a conference, and one of the keynote speakers there at that conference was a gentleman who was involved in a serious motor vehicle collision. He was less than 1 mile from a level 1 trauma center, and he had major facial trauma, he had head trauma, major facial trauma, and if not for the paramedic there who did an emergency cry right there in the street, the patient would not have survived. And so it just goes to show you, I mean, he's 1 mile from that level 1 trauma center, but without an airway, your patient will surely die. And so it's why it's so important for us to be prepared at our level of training, be prepared to manage that airway and provide that oxygenation and ventilation. All right, and so the patient care goals here are to maintain a patent airway. We want to recognize and alleviate respiratory distress promptly, and we want to plan for the potential difficult airway. And so really what we need to understand is be prepared to maintain an airway, but also be prepared to recognize the differences in respiratory failure versus respiratory distress. We're going to provide effective oxygenation and ventilation. Now, again, we used to hyperventilate every patient that we came in contact with that we felt was hypoxic. Not the case anymore. We understand now that hyperventilating patients can affect blood pressure. It can affect a lot of things. So our goal here is for an SpO2 from 94 to 98%. Also, we're going to use end-tidal CO2 effectively when we're monitoring these patients. Capnography will tell us right away if a patient's slipping into a hypoxic state. We're going to implement quick and safe interventions. We're going to address respiratory support needs in medical and trauma cases. So when it comes to assessment and monitoring, history taking, right? History taking is important because I don't know if you realized it yet or not, but asthma is a really prominent respiratory disease process inside our community. Almost every patient you come in contact with here in DeKalb says that they have asthma, but do they? Because a lot of times it's more of a bronchitis history than an asthma history, and that could be important if we're deciding how to treat this patient between congestive heart failure versus asthma. If we treat that patient who's in CHF like an asthma patient, well, we're not going to get too far. A lot of the treatments there could actually be detrimental to that patient. Time of onset of symptoms, associated symptoms. When we're talking about wheezing, for example, is that that can be associated with CHF, a high pitched wheeze, but Is this an asthmatic wheeze, or is it what we call like a cardiac asthma wheeze? Again, history, right? Asthma versus COPD. Triggers for this dyspnea, right? So lying flat, right? Is this person in distress when they lie flat? That's a definite sign of congestive heart failure. If their distress is worse, lying flat. That's why we ask about pillows. Have you found yourself the last couple of weeks using, sitting up in a chair to sleep? Evidence of upper airway obstruction or trauma. We want to do a good physical exam. We want to observe that respiratory pattern. We want to look at rate and effort. You can tell when you walk in the door if this person is, lying on the couch and they're complaining of difficulty in breathing versus the patient who's sitting tripod in a chair complaining of difficulty in breathing. We want to look for those accessory muscles and we want to pay attention to cyanosis. We're going to assess breath sounds. And we're going to evaluate skin color and their mental status. Remember, mental status is one of the first things to reflect a patient who is in severe hypoxia. And when it comes to monitoring, again, we're going to use pulse ox and we're going to use our ETCO2. And the goal there is 35 to 45. All right, patient, again, continuing with management techniques. We're going to look at oxygen administration. We want to start with a nasal cannula or a non-rebreather mask as needed. We also need to, again, it goes back to, can this patient inspire or not, right? Because if they can inspire, that means they can get oxygen to the alveoli, and that we can start with something like that and see where we're at. But if this patient has less than an inch of chest rise or fall, then we're going to have to provide positive pressure ventilation. And that positive pressure ventilation might be bagging the patient, or it might be the use of CPAP. Basic airway techniques. We have to ensure that, as easy as it seems to do a head tilt chin lift, can we maintain that airway with just a head tilt chin lift, right? Because what ends up happening is we start with a good head tilt chin lift, and then the next thing you know, the patient's head seems to slide down and the tongue blocks the airway. And so that's why the use of adjuncts is so important, whether it be an oral airway or even a nasal airway. And we got to know, when is it appropriate to use those? Well, we know that an oral airway should never be used with anybody with a gag reflex. And we know the nasal pharyngeal airway would be a good airway to use if they do have a gag reflex. We just talked about patient positioning, but let's think about this some more. If you have a patient who is in moderate to severe distress and they're unable to maintain a position, let's set them up. Let's get them in a position where mechanically they can breathe better. Suction, again, we need to check our suctions when we start the shift. We need to make sure they work. I know for a fact that we don't use that piece of equipment every day. And when we need it to work properly. And we need to know how to use it. We need to make sure it works. We need to recognize the bag valve mass, and we need to make sure that when we are ventilating using that device, that we have good chest rise and fall, and that that ventilations are being delivered. Don't forget about the 2-person technique that's preferred when using a BVM. And this about PEEP here is more about those BVMs that have adjustable PEEPs. Ours do not. Let's talk a little bit about advanced interventions here. When we use the use of CPAP or BiPAP for for severe distress or impending failure. And so these are those patients that you're going to have in the field that are super hypertensive. They're preloaded out. They may or may not have lower extremity edema. These are the patients, so that we have to recognize that CPAP could be beneficial for these patients. We need to coach these patients when we're putting them on the CPAP. They may have never had it applied before, and we need to coach them through that. It's already terrifying enough when you can't breathe, and now I'm going to put something over your face. So it's really important to say, hey, look, I know that this seems like it's smothering you, but I want you to really let me help you. Let me put this on your face. And once I do put it on their face, I want you to relax. I want you to take some deep breaths with this device. Make sure the mask seal is important, making sure that it fits the face. And when you first put it on, you may have to actually hold the seal in place while your partner helps to put the head strap on. Supraglottic airways, that what we're talking about right now in class, when you come for skills, consider if BVM alone is insufficient. Remember, the airway emergency is over once the oral airway is in place. There doesn't need to be a rush to put in the supraglottic airway, but there comes a time and place when it could be important to do. Let's pre-oxygenate our patient first. Let's don't just let our patient sit there not breathing while we assemble the equipment needed for the supraglottic airway. No, let's don't do that. Let's provide good basic airway management. Let's put that oral airway in. Let's bag this patient for several minutes before we consider the advanced airway. That goes for paramedics as well for considering an advanced airway. Let's manage the airway with basics first, and then let's consider moving to something more advanced like an endotracheal intubation, which the scope of practice of the AEMT, you may not perform this skill, but they want you to be aware of it. That's why you're suctioning through an endotracheal tube. They want you to understand the process behind endotracheal intubation as well. Just like in EMT school, you may not have been taught how to put in a supraglottic airway, but they want you to be familiar with how it works. Same thing here. So indications, failure of less invasive methods, airway protection, or severe trauma. Those are the indications for endotracheal tube intubation. Optimize the first pass success. This is super important when it comes to any advanced airway. We want this to work on the first time because the patient is becoming more hypoxic while we are trying to attempt an intubation or putting in an iGel or combi tube or whatever for an advanced airway. We want it done right the first time. Now, it's not always possible. It's just not. It's not always possible for the first attempt, but that's okay. We should be prepared for backups. We need to pull that advanced airway out. Let's bag the patient. Let's have all of our equipment needed there, suctioning in case the patient needs to be suctioned, so that on our second attempt, hopefully successful, but the goal here is first pass. We want to secure the tube, and we want to confirm placement with waveform capnography. Then post-intubation management or post even iGels or etc. Sedation and appropriate ventilation settings. You will talk about the auto vent tonight. It has two selections. It has one for tidal volume. 500 is where we normally start out at, and the breaths per minute. And that going to depend on what your end tidal is. If your patient has an end tidal of 60, then we may ventilate that patient faster than that of a patient with a normal end tidal. So ventilation settings can differ, but sedation will be important as well. And I realize that's out of your scope, but you may be doing a critical care transport from facility to facility and the patient's on an auto vent. Well, that patient needs to make sure that they're sedated. And continuous monitoring for tube displacement. And it's super important once you put an advanced airway in that you can prove that you're oxygenating that patient. Let's say the patient gets to the hospital and the physician there thinks that tube's not in. It goes into the chart and the patient dies or has a poor outcome. The family may want that chart reviewed and look here, we have notes from a physician stating that the patient was poorly oxygenated by EMS. You get what I'm saying here. You need to make sure that you have proof on your end that end-tidal CO2 was on. We had 35 to 45. We were managing that airway. The patient was not hypoxic. We need to have records of that. In case that does go further, it's in our patient care report. We can upload that data from the monitor into the patient care report. All of that's super important. Pediatric considerations. So we want you to prioritize BVM ventilation over intubation, right? Or even other advanced airways. As studies have found that pediatric patients do much better when managed with an oral airway versus an advanced airway. We want to make sure that the appropriate size equipment based on age and weight is at our disposal. And we emphasize non-invasive techniques when possible, right? So we want to make sure that we're least invasive to the most invasive, right? We don't want to just start with tubing a kid. We don't want to just start with putting an advanced airway in with a child. And we're seeing some of this data transfer to adults as well. If we manage the airway with basic tools and oxygenate the patient for a little while, let's get these SATs up, let's get this patient oxygenated, they have better outcomes. Remember, in your children versus your adults, their tongue is proportionally larger, right? And so that's something we have to remember. Patient safety considerations. Avoid excessive tidal volume or pressure during BVM to prevent barotrauma. We don't need to pop a lung if we don't need that. So let's avoid that. We want to provide just enough air for that chest to rise and fall. We want to limit hypoxia and hypotension during intubation attempts. Guys, if you're out there and you have a critically ill patient who's going to require airway management, if they're hypotensive and their pulse ox is low and you start trying to put an advanced airway in, you're going to kill that patient. There's proof of that. So let's don't do that. Let's bag that patient with an oral airway or nasal airway. Let's do that stuff. Let's get that oxygen saturation up along with the blood pressure before we attempt to do any advanced airway procedures. Suction. We want to suction aggressively to prevent aspiration, right? So if that patient airway needs to be suctioned, then we need to do that. And we want to ensure advanced airway devices are secured properly to avoid displacement. Document and quality improvement. We need to record the initial and post-interventional vital signs, right? We need to document that if we were going to put an advanced airway in, that patient's hypotensive and they're hypoxic, let's show something in our report that what we did to correct that. And then we tried to manage the airway a little more aggressively. But we need to document those airway interventions. We need to document the equipment that we used. And don't forget, document the response as well. when we're talking about quality improvement, we're trying to track performance measures, first pass intubation success rates, and the documentation of ETCO2, entitled CO2, and SPO2. Guys, in conclusion of this evidence-based medicine PowerPoint, but we want to really recap the importance of airway management in pre-hospital care, right? There's lots of lives out there that are saved I won't say every day, but I mean, quite often there's lives saved out there every day by those who understand the importance of recognizing the difference between respiratory failure and respiratory distress. Those people who start with basic maneuvers and work their way up to advanced maneuvers, right? All that's super important. And really, when you have a sick patient, using the tools that you have, right, entitled CO2, and paying attention to those readings. And when you get a monitor that shows a pulse ox of 88%, of investigating that, right? Is this a dirty fingernail, or is this patient really hypoxic? We take it at two steps ahead. We'll listen to those lung sounds a little more clearly. We're looking at that chest rise and fall. And also, when it comes to airway management, it's a skill that has to be practiced. It's a continuous practice, and we really have to pay attention to how we're documenting these calls. All right, that is all I have in this PowerPoint. I think this is going to conclude the PowerPoints for Airway, and just reach out to me if you need further assistance. All right, see you in class.